Dr. Eichelboom's a hard act to follow. I'm going to just try to say some controversial things to spice up my talk, but I didn't actually think there was anything that controversial here, but you never know. These are my disclosures. So platelets are important in thrombosis. Platelet activation and aggregation are essential to thrombus formation in response to a variety of different disease states. And for that reason, antiplatelet agents have been found to be quite useful. Thromboxane inhibitors, such as aspirin, of course, have a prominent role in cardiovascular medicine, and as we just learned, in DVT prophylaxis as well in certain circumstances. The ADP receptor has been the focus of a great deal of inquiry. Lots of different agents have been and are being examined that target that receptor. The PAR1 receptor and PAR1 antagonists are currently being studied, and glycoprotein 2b3 inhibitors are another important class of antiplatelet agents that I won't discuss because the oral versions of them didn't work. Let me start off with the ADP receptor. This is an important receptor as a target for different pharmacological agents. The P2Y12 receptor subtype in particular seems to be the one that is most relevant as far as pharmacotherapy, though there are some investigational agents that target some of the other ADP receptor subtypes. Dr. Goldhaber asked me to talk about new things in the world of antiplatelets and updates, and so you might wonder, why am I showing this paper from 1996 from the Lancet, the CAPRIE study. This was the study that initially led to the approval of Clopidogrel for secondary prevention. This study examined patients with recent ischemic stroke, recent myocardial infarction, or symptomatic peripheral arterial disease, so really high-risk secondary prevention, randomized them to aspirin monotherapy or Clopidogrel monotherapy, and found that Clopidogrel was superior over the course of about 3 years for reducing MI, ischemic stroke, or vascular death, an 8.7% relative risk reduction that underwhelmed many physicians. But the reason I present it now is that it is 2011, and next year Clopidogrel will be generic in the US. It's already generic in many other parts of the world. So I think these data will be revisited and met with much more enthusiasm once the price differential between aspirin and Clopidogrel narrows. Of course, Clopidogrel, even once multiple generics are available, won't be quite as cheap as aspirin, but still, I think many clinicians will think the 8.7% risk reduction is worth it once that price of Clopidogrel is lower. In particular, I think as one examines higher risk subset data from the overall CAPRIE trial, what emerges is a consistent pattern, that is higher risk patients, such as those with multiple ischemic events who were enrolled in the trial, have a larger relative and, for that matter, absolute risk reduction when they were randomized to Clopidogrel versus aspirin. So I think that we'll see a lot more use of Clopidogrel in secondary prevention, Clopidogrel monotherapy instead of aspirin monotherapy in higher risk secondary prevention. This slide summarizes some data from the Charisma trial. This examined not Clopidogrel versus aspirin, but dual antiplatelet therapy, Clopidogrel plus aspirin versus aspirin alone, in stable secondary prevention and high risk primary prevention. So not ACS patients or stented patients where Clopidogrel plus aspirin have lots of data supporting their use, but rather a much more stable long-term population. And the overall trial was negative, not finding a benefit for dual antiplatelet therapy over aspirin alone, though the secondary prevention cohort did seem to have some signal of benefit. And drilling down on patients from the overall Charisma trial that were like those in the prior CAPRIE trial, in this rather large subgroup of 9,000 patients, there did appear to be a benefit of dual antiplatelet therapy in green versus aspirin alone in blue over the course of about 3 years, a 17% relative risk reduction, a 1.5% absolute risk reduction. So we've got to be cautious about interpreting subgroup data in an overall negative trial, but there are at least 3 or 4 ongoing randomized clinical trials that are testing this concept of dual antiplatelet therapy versus aspirin monotherapy in various high-risk secondary prevention populations. So we'll see whether the observation in this trial holds up in a prospective fashion. Other things in the world of antiplatelet therapy that are relatively new have to do with proton pump inhibitors. As you're likely aware, there's been a lot of discussion about a clopidogrel, a PPI interaction, that is an adverse interaction such that PPIs, and depending on the study, either all PPIs or certain PPIs, blunt clopidogrel's efficacy. The only randomized clinical trial to evaluate this question was the COGENT trial, and this study took patients with ACS and with stents who had an indication for clopidogrel plus aspirin, and then randomized them to a proton pump inhibitor, omeprazole versus placebo. And the trial wasn't designed to evaluate for an adverse interaction. It was designed to see if there was, in fact, gastrointestinal benefit to a strategy of prophylactic proton pump inhibitor in patients who weren't specifically at high GI bleeding risk other than being on dual antiplatelet therapy. And the study showed for the primary GI endpoint a significant reduction, a hazard ratio of 0.34 in favor of the proton pump inhibitor versus placebo. And in fact, this is the first randomized clinical trial to show that a prophylactic proton pump inhibitor reduces clinical gastrointestinal bleeding. The prior PPI work had shown reduction in endoscopic endpoints in patients on aspirin or on no antiplatelet therapy, or had shown reductions in recurrent GI bleeding in patients with previous GI bleeding. But this is actually the first time that a PPI had been validated when given in prophylactic fashion to reduce clinical events. But with respect to the cardiovascular endpoint, which was also prospectively defined and examined, there was no obvious adverse interaction between clopidogrel and omeprazole. The hazard ratio for cardiovascular events essentially is 1, so no evidence of harm. The one caveat here in interpreting the cardiovascular safety data is that this trial was prematurely terminated when the industry sponsor went bankrupt. So the number of cardiovascular events is limited, but still within this early period of 6 months, where one would expect the highest risk of things like stent thrombosis in an ACS patient, I think it's reassuring that there was no excess in cardiovascular events. Other data with respect to clopidogrel that has been controversial has been that of clopidogrel resistance, or variability in response, as it's probably more appropriately termed. And as you're likely aware, there's a bell-shaped distribution to the antiplatelet response that an individual may have to clopidogrel, with folks that are on either end of this bell curve, either being hypo or hyper responders, potentially predisposed to ischemic or bleeding events, depending on which end of the curve they are. And to see whether overcoming antiplatelet resistance by dose modulation would be useful, this particular study, which is a current OASIS 7 study, was done at Dr. Eichelboom's institution. And this trial took ACS patients, 25,000 of them, and randomized them to either standard dose clopidogrel or double dose clopidogrel for a week, followed by standard dose clopidogrel. And what the study found overall was a significant reduction in stent thrombosis in those patients getting the double dose clopidogrel regimen versus the more standard dose, and this was statistically significant. So I think in patients that are going on to PCI who have ACS, there is a reduction in stent thrombosis with more potent antiplatelet therapy, and that includes doubling the clopidogrel dosing for that first week. Another area of interest and perhaps controversy in the clopidogrel story has been that of genetic polymorphisms and the impact on clopidogrel. And this was the first genome-wide association, or GWAS study, that found that this particular polymorphism, CYP2C19, STAR2 in particular alleles, predisposed or were associated with a higher rate of cardiovascular events. Certainly, those polymorphisms of CYP2C19, STAR2, STAR3, a few others, reduce the amount of active metabolite of clopidogrel that's produced, so it's logical to think that it should increase the rate of ischemic events if a patient with one of these polymorphisms happens to be on clopidogrel. So this particular study, I thought, did raise that question and certainly showed an association. But the real question, though, is with these sort of data as far as polymorphisms, and a lot of them are pharmacokinetic and pharmacodynamic data sets, is this concept of tailoring antiplatelet therapy justified? How well did the data fit? And there's a lot of data, and for the sake of time, I'm not going to summarize it, but rather go to what I think is the best study in the field. Actually, Dr. Eichelboom was the senior author on this, and this is an analysis from the CURE trial, which was initially published in 2001, but this genetic analysis was just published last year. And what the CURE investigators did was go to the blood that they had wisely saved from that analysis, from that study, the CURE study, and analyze different genetic polymorphisms, such as 4CYP2C19, to see if the polymorphism status affected the response to clopidogrel versus placebo in this large placebo-controlled trial. And unlike all the other observational data sets that had been examined previously, this study had the benefit of having a placebo-controlled arm. And when examined in that light, there was no apparent effect of various clopidogrel polymorphisms related to CYP2C19 and clopidogrel's benefit versus placebo. And for that matter, no effect on the bleeding risk conferred by clopidogrel versus placebo. So what I conclude from that very elegant analysis is that CYP2C19 polymorphisms aren't worth measuring because it doesn't affect your decision to use clopidogrel versus placebo in an ACS patient. So interesting science there, but I think we need a lot more work before we actually start measuring these polymorphisms in clinical practice. The other area that I think also probably does deserve the label of controversial is that of platelet function testing. So not genetic polymorphism testing, but actually testing in a point-of-care assay, for example, or even just in a laboratory assay, how platelets respond to clopidogrel. And a number of studies summarized on this table, and there are even more studies, show that patients with high platelet reactivity do poorly. That has been shown if they're on nothing, if they're on clopidogrel, more recently, even if they're on more potent agents like prasugrel. So there's definitely an association between having platelets that are angry and bad outcomes. But the real question for the clinician is, can you do anything about it? And if you can, then you should measure these tests. And if you can't, you shouldn't. And the GRAVITAS study was a prospective trial designed to answer this question, taking patients undergoing percutaneous coronary intervention and using a point-of-care assay, dividing them into responders or non-responders. And the non-responders were randomized to receive standard therapy, the FDA-approved dose of clopidogrel, or tailored therapy, double-dose clopidogrel. And the overall study and the primary endpoint of cardiovascular death, MI, stent thrombosis, showed no difference between the high dose and standard dose clopidogrel. And one might say then, oh, that just proves that high dose clopidogrel in the stable elective PCI population doesn't work. And that would seem to be true within the context of the sample size of this study. But more importantly, I'd go one step further and say, well, if the therapeutic modulation based on the testing strategy didn't work, well, that really means you shouldn't be testing because you can't do anything with that information. So much like genetic testing, I would put point-of-care platelet assays in that same bin of interesting science, needs more research, not ready in general for clinical prime time. Much more important than worrying about genetic polymorphisms or point-of-care platelet assays showing heightened platelet reactivity, I think is the issue of non-adherence to medications in general, antiplatelet therapy in particular. And I think that the non-adherence part of this pie chart really dwarfs environmental or genetic factors. That's not to say environmental factors or genetic factors don't affect response to clopidogrel or antiplatelet therapy in general. But I just think from the perspective of the clinicians that are in this room, you're better off focusing attention on non-adherence. This is a complex issue. There are a lot of things that predispose to non-adherence. But with antiplatelet therapy in particular, I think bleeding, a nuisance bleeding, is something that's been underappreciated. A lot of times clinical trials say, oh, it's a little nuisance bleeding. Not an issue, but in particular outside of clinical trials, a little bit of nuisance bleeding, bleeding while shaving, brushing teeth. While we might say, oh, that's not such a big deal, it's worth remaining on your antiplatelet agent for all the good things it does. Well, from a patient's perspective, if they're bleeding, maybe they'll think that medication can't be that good for them. So I think there's a lot we can do in terms of education and education of patients and telling them what side effects might be acceptable, and just getting a sense of what their viewpoints of that are. Well, let me move on now to some novel antiplatelet agents, such as Prasugrel. This is a more potent version of Clopidogrel, more efficiently metabolized, such that basically there's more active metabolite that gets to the ADP P2Y12 receptor, and therefore it is more potent. And the clinical data from the Triton study, the overall trial, as well as now several subset analyses, such as in patients with MI and with diabetes, show pretty large and significant benefit for the more potent agent, Prasugrel versus Clopidogrel, a risk reduction of about 20% in relative terms, and in absolute terms about 2% over the course of 15 months. So in ACS patients undergoing PCI, Prasugrel does seem superior to Clopidogrel. Now, of course, with a more potent agent, more bleeding does occur. That was not unexpected. There was slightly more fatal bleeding that occurred as well, so obviously there needs to be some care in patient selection. You wouldn't want to use Prasugrel in patients that are at very high risk of bleeding. The other caveat is that in patients with stroke or TIA in this study, there was a higher rate of intracranial hemorrhage with Prasugrel versus Clopidogrel, so Prasugrel shouldn't be used in patients with known prior stroke or TIA. An important study that's ongoing with Prasugrel is the Trilogy trial being run out of Duke University, and this study is taking about 10,000 patients with ACS who are being medically managed, and those patients are randomized to either Clopidogrel or to Prasugrel. So a few important points about this study. One is that it's the initial medical management of ACS patients, unlike the Triton trial, which was ACS managed with PCI. So these are patients where the initial plan is to manage them medically, as happens in probably a third of ACS patients. And a couple of interesting things about the way the trial is designed is that there's dose modulation, so not changing dose or tailoring therapy based on genotype or point of care testing, but based on phenotype. That is, in patients that are aged greater than or equal to 75 years or who are weighing less than 60 kilograms, the maintenance dose of Prasugrel that's going to be used in this trial is 5 milligrams instead of the more conventional 10. So using this dosage modulation, we'll see what happens with the relative ischemic versus bleeding benefits of Prasugrel versus Clopidogrel. The study's well underway, so hopefully we'll have an answer as far as what Prasugrel's role may be in the medical management of ACS. The final sort of new oral antiplatelet agent that's out there and now available is Ticagrelor, just recently FDA approved, and this is also a ADP receptor antagonist like Clopidogrel, Prasugrel, but a couple of differences that might be important. It is a reversible agent, so unlike Clopidogrel or Prasugrel or aspirin for that matter, it is reversible, so the irreversible agents, when you take them, they're there for the lifespan of the platelet. With Ticagrelor, its effect, depending on the dose and how long you've been on it, wears off in a couple of days, though the full effect can linger for a little bit beyond that. But still, potentially an advantage in a patient that might need to go on to a surgical procedure, bypass surgery, for example, in the case of an ACS patient. And the pivotal trial for Ticagrelor was a Plato trial that took ACS patients, randomized them to Ticagrelor or Clopidogrel for a year, and found a significant reduction in cardiovascular death, MI, or stroke. Again, similar degrees of risk reduction in relative and absolute terms as compared with Triton, and also as compared with CURE, which was a Clopidogrel versus placebo trial. So it's important to realize for both Triton and Plato, this is Ticagrelor versus Clopidogrel. If there were a true placebo arm, if we imputed, say, the placebo arm from CURE, that would be up there. So the risk reductions for Prasugrel and Ticagrelor versus placebo actually are huge if one views them in that light. As far as secondary endpoints in the Plato trial, myocardial infarction was reduced. That's expected with an antiplatelet agent. Interestingly, though, cardiovascular death as a standalone endpoint was significantly reduced with Ticagrelor versus Clopidogrel, about a 1% absolute risk reduction. So about 1 patient out of 100 less likely to have a cardiovascular death had they been randomized to Ticagrelor versus Clopidogrel. So I think that's a pretty important finding. Major bleeding overall, using the Plato definition, wasn't significantly increased for ticagrelor versus clopidogrel, but I think if one drills down and compares like to like and uses, say, non-CABG Plato major bleeding, or perhaps the more standard non-CABG TIMI major bleeding, well, there was an increase in bleeding with ticagrelor versus clopidogrel. That's not unexpected with a more potent antiplatelet agent, and is similar to what was seen in Triton, or for that matter in CURE for clopidogrel versus placebo, similar degree of relative risk increase. The one interesting point about bleeding, though, is that surgical-related bleeding wasn't increased with ticagrelor versus clopidogrel. In fact, was a little bit lower numerically, though not statistically significantly lower. So, again, maybe some advantages around the time of bypass surgery with that agent. As far as ongoing trials with ticagrelor, the Pegasus trial was recently launched. This is a study that the TIMI group's doing, examining about 21,000 stable patients randomized to either the current FDA-approved dose of ticagrelor for ACS or a lower dose of ticagrelor or placebo. It's a long-term study, very similar to the high-risk cohort from Charisma, to see whether extended durations of dual antiplatelet therapy are indeed warranted or not. I'm just going to make a few comments about a couple of other antiplatelet agents that are out there. Cangrelor is an intravenous antiplatelet agent, not an oral agent, and it is very fast onset, fast offset. So from an interventional cardiologist perspective, it's got a lot of desirable traits. It's been evaluated already in 2 trials, Champion PCI and Champion Platform. The exact details may not be so important for this talk, but just to summarize the results, the Champion PCI trial, which essentially compared Cangrelor to 600 of clopidogrel, failed to show superiority of Cangrelor, though it did find non-inferiority of Cangrelor compared with 600 of clopidogrel. The Champion Platform study likewise failed to meet its primary endpoint with no significant reduction in death, MI, ischemia-driven revascularization with Cangrelor versus placebo with clopidogrel given at the end of the procedure. However, some secondary endpoints did seem to be favorably influenced, including stent thrombosis and death. And just to drill down upon the stent thrombosis, as you can see here, a significant reduction in the stent thrombosis rate over the 48-hour study period. And likewise, mortality parallel that stent thrombosis finding, where there was a significant reduction from 0.7 to 0.2% in mortality. So based on those secondary endpoints and those promising signals, a third study of Cangrelor is underway, the Champion Phoenix trial. And that study is, again, examining intravenous Cangrelor in PCI patients, basically all comers, those with stable angina, unstable angina, non-STEMI, and STEMI. Another agent that's out there in evaluation is Alinigrel. This is an agent that's interesting because it's an ADP receptor antagonist also, but it is available, or not available, but being studied in both intravenous and oral formulations. So Cangrelor is just an intravenous ADP receptor antagonist, clopidogrel, prasugrel, ticagrelor are oral ADP receptor antagonists, but Alinigrel comes in both forms. And in a phase 2 study called Innovate PCI, it appeared to be safe and effective within the confines of a phase 2 analysis. And in the pharmacodynamic sub-study from that trial, it appeared to provide an effective degree of platelet inhibition when compared with clopidogrel. So potentially this agent will be studied further. That remains to be seen. And the final class of compounds I'll mention are the thrombin receptor antagonists, or the PAR receptor antagonist. Thrombin, as you are likely aware, is a very potent stimulus to platelet aggregation, and one might think that inhibition of PAR receptors might therefore be associated with clinical benefit. There is a large ongoing program with Vorapaxar, a PAR receptor antagonist, being studied both in ACS in the TRACER trial and in secondary prevention in the TIMI 50 trial. And in total, there's about 40,000 patients that are being examined with this compound versus placebo. The TRACER trial will be presented as a late-breaking trial at the American Heart Association, so we'll hear very soon whether this compound and whether this class indeed is promising or not. A related compound, a PAR receptor antagonist, is adapaxar. This has been studied in 2 phase 2 trials, actually 4 if you include the Japanese versions, both in ACS and stable CAD. And these data have been published in circulation in the European Heart Journal at this point. Overall, it shows efficacy and safety within the confines of a phase 2 program. In fact, the ACS trial showed for the first time a reduction in Holter-defined ischemia with a oral antiplatelet versus placebo. Whether this drug goes on to phase 3 development, I don't know. Probably or possibly will be contingent on the fate of vorapaxar in its development program. So to conclude then, dual antiplatelet therapy is indicated for at least a year after ACS and or PCI. The older Clopidogrel trials, CURE, PCI CURE, CREDO, showed us that. There's a potential benefit of dual antiplatelet therapy beyond a year in patients with ACS. The Charisma subgroup data suggests that. The Triton study actually shows it, since that was a 15-month and not 12-month study. Novel agents have been evaluated and appear to reduce ischemic events. Both Prasugrel and Ticagrelor significantly reduce ischemic events, but both do increase bleeding, so some careful patient selection is needed with those novel agents. And finally, the relationships between genotypes, pharmacokinetics, pharmacodynamics, point-of-care platelet assays, drug interactions, and clinical outcomes are really very complex, and you can really think yourself into a corner examining all the data as it comes out. But I think right now for the clinician, these are things to be aware of, but not really to act upon. Thank you very much for your attention.